go ahead and kick off today. Thank you for joining us as we get to discuss and meet AI measures. We'll kick off to the next slide, and I'll introduce myself and then Dr. Thomas Frazier. My name is Nissa Intarachote van Etten, and I am the Director of Clinical Training and CR Institute here at CentralReach. I'm really excited to be hosting this webinar with Dr. Thomas Frazier. I've been in the field for about 25 years, certified for 17, and really love the topic of assessment as well as evaluation and designing objective treatment goals for learners. So I'm looking forward to supporting Dr. Frazier here today. And Dr. Frazier, do you want to go ahead and introduce yourself before we go on to housekeeping?
Yeah, sure. No, thank you, Nissa. Yeah, Tom Frazier, I'm a clinical psychologist, and with my wife, Allison, who's a BCBA, and our collaborators at Nationwide Children's and Stanford, we developed AI.Measures, and we'll be talking to you about it today, but I know Nissa has some housekeeping to do.
Absolutely. Before we jump into the great topic that we're discussing today, just a little bit of housekeeping for you all. If you have any questions as you're watching this webinar, it's going to be super informative and hopefully it will really bring up some thoughtful questions for you. Please use that Q&A button. We've got our CentralReach team as well as Allison Frazier on the call to answer your questions live. If there's a question for either of us on the panel, we'll go ahead and answer those as they come through. The team will let us know. The recording, if you are not able to attend and you wanted to access the recording, it will be sent to you in an email in the next 2 to 3 business days. We just wait for the video to process. So thank you for joining us. We're going to jump right in.
Awesome. Yeah, so thank you, Nissa. Just in terms of the agenda, we're going to introduce AI.Measures and then talk a little bit about aspects of our decision support that help with dose and strategy, which are important considerations, obviously, at baseline and ongoing through the authorization process for ABA services, and then integrating AIM into the process, and then hopefully giving you some demonstration of AIM functionality, although we'd love to schedule time to go in more detail with you and talk to you about how it could fit into your practice and how we train individuals to use the system. So before I move forward too much, I do want to just mention that Allison and I really developed AIM because of our history in autism and our practice. We have a 21-year-old son with autism who's received ABA services for many years. I oversaw the Cleveland Clinic Center for Autism ABA services. Allison was also involved in that, and we've practiced for about 20 years, each of us. So it's really based upon our clinical experience. And I'm an assessment person, so I'm also very interested in trying to improve the assessment processes for ABA, make it smoother, more efficient, more effective. I seriously doubt that anyone watching this webinar now or watching the recording in the future that I need to convince you of the value of ABA services. But what I do want to say is that, you know, beyond the things that we immediately target, there are oftentimes many ancillary benefits. So both direct and ancillary benefits. And we know there are a number of co-occurring conditions in autism: anxiety, ADHD or attention problems, intellectual disability, mood, irritability, sleep, etc. And ABA improves those areas as well, sometimes when we're not even targeting them. And if we want to move to a value-based or measurement-based care framework, it's really crucial as providers, both for our patients themselves, but also to show to our payers that we are providing a wide range of benefits to the patients that we serve. And so that was a major motivation behind AI.Measures. You know, to move to value-based care, we have to have good measures of clinical quality. And I would actually argue that we really need 5 things to move to value-based care. Those 5 things are: we have to have the domain coverage I just talked about, because if we don't, we're selling ourselves short and we're selling our patients short, frankly. We have to have aggregate measures. When you think about value-based care, a lot of our payers are thinking in terms of things like diabetes with A1C, where you have a single metric or a very small number of metrics. And so at AI.Measures, we're able to aggregate domain scores into single metrics that we're calling core ABA outcome metric. And you also need to have standardized approaches, right? Standardized measures, including norm referenced and skill-based or criterion referenced or curriculum-based measures. And some of those are subjectively collected and some of them are more objectively collected, but you have to have both because, right, you can't measure quality of life objectively, right? But at the same time, we want to do the best job we can in terms of getting really good, clear data. The fourth thing I would argue is that because autism is such a variable condition, that we have to have attribute or severity adjusted metrics to evaluate patients. We need to know how a patient is doing to how we would expect them to do, right? Because more significantly impacted patients have different expectations than individuals with really strong cognitive and behavioral profiles. And if we don't do this, if we don't do attribute or severity adjusted change, then those that are most impacted could get left behind, and we don't want that to happen. And then the fifth thing I would argue is that especially as payers are getting more sophisticated about how they authorize services, we need to understand what is the appropriate strategy. What are we asking for here, and how are we engaging in the right strategies? And I'll talk more about this when I talk about our dose and strategy tool, but I just want to tell you that, like, for example, my son received ABA services from a very young age, but for the first year or so, he didn't show as much progress as we would have liked, and it was because the strategy wasn't right. And once we got the strategy right, he started to take off, just like a lot of kids do in ABA services when we get it right. So those are the 5 areas that we really built AI measures around. And I would also just say that we looked at the legacy assessments and we realized very quickly, and I'm a measure guy, so I really took a deep dive here, and I'm going to spare you the details, but they lack the characteristics needed to do this. They have a lot of psychometric limitations, but even more than that, they have practical limitations for using them for ABA services and longitudinal monitoring and clinical quality improvement. So we really thought, okay, it's time for us to develop a measure set and a platform that works for ABA. And
And
so
I want
what
to
is that?
interrupt you
Go ahead.
really
Yeah,
quickly,
please.
Dr. Frazier. I do have
Yeah,
two questions that come to mind as you
yeah,
discussed.
please.
One, as a behavior analyst and something that I've seen in the field, and a question I imagine some of our participants and listeners might be wondering is, what is the level of training required for clinicians, especially BCBAs, to administer a tool like AI.Measures or to evaluate some of those tools that you're discussing and those psychometric properties when we might not have that level of training?
Right. So, I mean, I think obviously programs are starting to catch on that this is an important part of training. And so I think some of the earlier career folks are starting to get maybe a different type of training and more experience with this. But I will tell you that, we do train everyone who comes onto our platform. We have asynchronous trainings. We also do live trainings. And we want people to feel comfortable. So that's part of it. The other part of the answer is we tried to build our platform to make it easier on folks. You don't have to be a psychometrician to use our platform. You can be a great clinician and you can go into our platform and say, "Hey, this makes sense to me." And I think as we show you some of the features in our platform, you'll see that we tailored it around BCBAs using the platform.
Perfect. I'm looking forward to that part.
Yeah. Did you have another question?
I'm going to hold that one because I think
Okay,
I'm going to
great.
discuss it a little bit.
Yeah, so this side just kind of gives you an overview of what we are as a platform. We have standardized norm referenced assessments, all of which have been validated and published in the peer-reviewed literature. We have decision support tools, including our dose and strategy tool. We have the ability to do assessment-driven treatment, meaning that the assessment results guide recommendations that the clinician can then select around intervention targets, and then use those targets to develop goals and objectives and teaching plans. And then ultimately progress monitor that information. So we're trying to put everything in one spot so that you can truly do assessment-driven treatment. We know that that's the future of how outcome assessment is going to be done in ABA. So ultimately, people are in different settings, and we know that this is a really inefficient process today, right? We know that people struggle with the process today. My wife kind of came to me originally when we started this, talking and telling me about how many inefficiencies there were in the process. So we're just trying to improve that. We're trying to translate results into more effective intervention plans, optimize the way which we go about therapy, and then monitor that over time and iteratively improve and do the kinds of clinical quality improvement for individual patients and for practices. So what are our assessments? Well, we have 2 types in the system right now, and then we'll tell you about some things we're adding in the coming months. So right now we have 10 different parent caregiver survey scales or rating scales. They cover a total of 12 different domains, including the two core autism symptom domains, social communication interaction, and restricted and repetitive behavior. We developed all of our measures, both our parent caregiver and our clinician educator measures, using FDA processes. The FDA has very clear processes about how to develop these measures and how to involve stakeholders in the process of measure development from the very beginning to when you deploy them. And we think that, as I said, this broad coverage here actually permits accounting for the benefits of ABA. And I've starred a few of the measures here. You can see 5 stars here: autism, quality of life, executive functioning, practical living skills, and challenging behavior, because those are the measures we recommend as our core ABA outcome assessment. And collecting those measures allows you to get that aggregate measure that we think is going to be so important for value-based care. On the clinician educator rating scale side, we have, again, 6 scales, 6 instruments, and we recommend collecting autism, challenging behavior, and executive functioning here as part of the core ABA outcome assessment. We've added these clinician educator rating scales because we think this really is going to increase sensitivity to the treatment effect. Clinicians are often the first people to see the change. And so being able to quantify that, and then also allowing you to see when the clinician sees change, but maybe the parent or caregiver is not seeing change yet. So it allows us to compare across settings, and it informs generalization and maintenance. We did everything briefly. So a lot of times when people see what we're doing, they say, well, that's a lot, that's a lot, well, how are we going to do all that? Well, I want to let you know that we created these because I'm a test developer. We created these to be briefer. We didn't want to replicate what the legacy assessments had done, because we know that if you overly burden parents, and believe me, I've filled these out many times for my son, if you overly burden parents, they actually give you bad data. And so you don't get what you need. And as a result, it's really an ineffective process. So we built our measures to be briefer, but have really nice coverage of the things that we should care about. We validated them across the lifespan, so it's very useful for people that have broader practices. They all have the right kinds of psychometric properties, and they're comprehensive but still efficient. Like I said, everything we've done is published. You can go to our website, AI.Measures.com. You can see the references, the links. I'm happy to talk through with people all of the validation and normative work that we've done. So this is just a product flow. You register, you choose the battery, and obviously we have recommended batteries, but there may be times maybe a patient comes in and they have significant anxiety, or they have ADHD symptoms, or maybe it's a mood or irritability issue, or maybe it's something else that you want to try to address. So you can choose the battery. It's online administered. It's automatically scored and reported. We try to have user-friendly reporting with lots of visuals. And as I said, decision support to make it easier on BCBAs who are already have a lot on their plate. And this is just showing some of the cross-sectional and longitudinal efforts that we make to build the right kinds of monitoring insights. And when you're just interpreting a baseline assessment, making sure that you know exactly what domains and subdomains are in the clinical range and maybe need to be addressed, and then giving you some guidance about how to address things. In many cases, BCBAs become the behavioral health home for a patient. We develop relationships with our patients, and the families look to us for guidance. And so our platform even gives additional guidance outside of the typical behavioral intervention strategies, because we want to be able to help BCBAs answer those kinds of questions and address those kinds of issues in an evidence-based way. So, this is, you set me up for this, Nissa. This is the iCHOM battery, and these are the time estimates. These are published time estimates for each of the measures, right? And you can see there's a large number of items. There's a huge time estimate, right? Now, if you did the net battery and the other things that are recommended by iCHOM in certain domains, you would have better coverage and you would be faster. Now, this says 64 minutes, but remember, that includes all of our measures and some of the extra measures that iCHOM suggests for leisure skills and family assessments, right? So if you strip those out, our full battery is closer to 45 minutes, and our core ABA battery is about 25 minutes for parents. And as I said, for the clinician educator scales, it's even shorter.
So when a family is accessing this, it sounds like the clinician would kind of, and I've used some of the other kind of digital assessments, we would enter their email, it would ping them, and they would have kind of their battery open up to start scoring and assessing.
Yeah, and I'll show you that when I register the patient
Okay.
later. Yep.
That's wonderful because I think that's the component, as someone who works with families, sending those out and then reminding parents, hey, I would love for you to score this. I want to get this back in the next week or two, and I want to discuss it with you. So there is that level still of collaboration between the clinician and the parent, and even
Yep.
looking at these time savings for the family, saying this is only going to take you this amount of time, or we can sit and do this, when I come in for the next parent meeting.
Right, and that's a great point. So we wanted to do this as remote assessment in part because, if you're a busy caregiver, you can fill this out on your phone right before bed or when you wake up in the morning or maybe when you're just waiting at an appointment or something, right? And being able to do that is such a convenience rather than having to pull out paper and pencil or make sure you have all of the information you needed in the right, spot. So I think it's a major convenience. And because it's a convenience, our data suggests that people complete these more accurately, that we have a lot of validity checks, we have less problems with invalid responding, and they do it faster because it's easier to do.
Yep, that's wonderful.
So yeah, so just quickly, I'll just hit on a couple of quick things. And we tried to build our measures in the absolute most modern and best way possible, having representative norms, better sensitivity to change, improved decision making. Um, we're the only measure set available that has looked at bias in terms of all of these demographic factors: age, sex, race, ethnicity, household income, and also diagnostic characteristics, like, for example, cognitive impairment. We're the only measure set, comprehensive measure set that can say we've done that work and our measures are truly free of bias. So we're comparing apples to apples in our cases. Um, and then the other thing is all of our measures have growth scores. And we know now that growth scores are the absolute most sensitive way to track change. We want to know when we're improving our patient's functioning. And so you need growth scores to do that. And actually, I would argue that you need more than just growth scores. You need attribute adjusted change scores. And so what attribute adjusted change scores do is they take the growth scores and they adjust them for the expected change for that individual's attributes. So if you just give us a little bit of information about the individual, we use evidence from the literature, including meta-analyses of over 100 behavioral intervention studies, to make that attribute adjustment. That is not something we made up out of our heads. That is actually evidence-based. It is really from the literature. And the other thing that we do, and I'll show you a little bit of this when we do longitudinal monitoring in our system, is we offer reliable change indices. We want to be able to show you when you've generated a reliable improvement. Or maybe there isn't been a reliable improvement yet. So you got to think about adjusting focus, modifying treatment strategy, maybe changing your targets up. But if you do have a reliable improvement, again, it's an opportunity, it's an invitation to think about what am I going to do next? And it's a way for us to standardize practice too, right? So across providers, we can say, hey, when we get reliable improvements, these are the things we think about. Do we need to change settings or maybe add a setting? Do we need to shift our focus to another area? Like, for example, if we've now shown reliable improvement in basic social communication, maybe it's time to work on some of those perspective taking skills now, or reciprocal interaction and relationship development skills.
So this
And
leads
then,
me,
go
sorry to interrupt you,
ahead.
Dr. Frazier,
Yeah,
to
okay.
consider how frequently should we be, administering this battery of assessments? And if we're seeing these trends change, are we seeing them done on a weekly basis, on a monthly basis? How is this indicated back to the clinician to kind of
Yeah.
reevaluate?
No, this is a great question. So we're trying to promote best assessment practice, and the way to do that is actually to offer people models where you're not getting penalized for doing more assessment,
Yep.
and that's our model, right? And that's what I love about our partnership with CentralReach too. Is when we came to you guys for the partnership, you said that's what we want to support. And so ultimately, if we're going to do this right, we have data, for example, in the behavioral intervention literature to show that there are subsets of cases where at 3 months you have to be shifting focus. If you're not shifting focus from baseline to 3 months, you're not doing that child right. You're not doing right by that child. So we want to encourage more frequent assessment. Now, obviously, payers have set schedules for assessment and for authorization, and of course, you should follow payer policy. But I just want you to know that for people that adopt our system, we are trying to make sure you are not penalized for doing better practice. And so if you've got younger kids or kids that are making really rapid progress, do more assessment. you're
Exactly.
not going to be penalized for it.
And that's something we've said over and over with CR assessments is, if you've got access and you're in there frequently, learners are going to be making rapid change, especially if we're new to intervention, you may see rapid change happening and waiting with the payer requirements might be too long.
Right.
So that's what we recommend as best practice as well.
So yeah, just quickly, I do want to move on. So in addition to our assessments, we also offer a dose and strategy tool. You give us some information about the patient, you conduct your baseline assessment, you fill out and use the tool, it informs treatment planning, and then you can also update it in the future, right? So you can do it at each assessment time point. And again, I'm a scientist. We want to make sure everything we do is evidence-based. We developed this tool using two meta-analyses of predictors of outcome and behavioral intervention. So this isn't made up out of our heads. This is actually an algorithm that is based on the literature. And it allows you, I think, my wife has told me this in her own practice, especially with earlier career folks, to not only identify the sort of dosage range that you might want to consider, and then of course always apply clinical judgment to that, but then also the strategies that you might want to consider for this patient. So if I if I move on here, there are a bunch of different strategy types that we talk to you about in our dose and strategy tool. And again, it's decision support. You may disagree with the advice, but at least it's there and it's getting you thinking about what is the right teaching strategy. What kind of learning type? Is this a more procedural learner? They learn by doing, or is this more of a conceptual learner? They learn by ideas. What are the progress expectations? I know back when I was at Cleveland Clinic, we really struggled with this. What do we tell the new families when they come in? How fast should we expect to see progress? What kinds of progress and what areas of progress are going to be a little slower for somebody? What should be our strategy for generalization and maintenance? How do we deal with social communication interaction and restricted repetitive behavior targets? So all of that kind of stuff is part of our decision support tool there.
And I'm going to pause here and a couple questions. The first one, I think, or the first comment, I think, is that dosing component in working with learners in providing ABA. That is kind of the craft of the clinical decision making. That's the experience of being a behavior analyst, your education and training, and as well as your experience in working with the learners. But having a tool that supports that dosage, that allows you to consider, hey, here's the learner you've inputted, here are the results, here's what we would recommend. That I think is a nice place to start as a clinician. It's a framework to start to consider, do I agree? And if I do, fantastic. And if I don't, why am I disagreeing? Am I considering, placement, parent, decision making, some of the socially significant goals? And I think that's a big piece that is going to help clinicians in making their decisions for treatment goals and objectives. Which leads into the next question. Someone in the chat did ask, does insurance cover this as a standardized assessment? So I know you might be going into that, but as we talk about value-based care as well as insurance-funded treatment, I know a lot of clinicians are in that, okay, I've got to design my treatment plan, I've got to conduct these assessments, and I also have to identify dosing. What is your experience in seeing how funding sources have responded with AI measures?
I would say in general, very, very well, right? These are standardized norm reference assessments. We have peer-reviewed published literature. Once we make the funders aware of these standardized norm reference assessments, which we have been doing over the last several years, the funders have responded really positively to it. My wife's practice has been using these measures for a long time, and she gets reimbursed. In fact, we have a case study of her practice where essentially there was one denial, and it was because the person forgot to put on the reference list and educate the payer. It was a new payer. And once we educated them, they were like, great, this is golden. This is exactly what we're looking for, standardized norm reference assessments. So I'm not going to say there aren't going to be hiccups. Listen, the authorization process is always tricky, but we are here to help you and to guide you in that process. And if you are getting problems along the way, we can definitely assist you with that. The important thing to know is that payer policies generally support standardized norm reference assessments, and once they know it's peer-reviewed, published, validated information, they're very receptive to it.
So I imagine there's a level of submitting your treatment plan with the AI measures, but also adding those references and educating the payers that this is a tool that is out there. Here's the research. And I know
Yes.
that can be done within the treatment plan as well as an attachment or an addendum to the treatment plan.
Right, exactly. And we put all of our references in our report, so they're already there for you.
Okay.
Right. So when you attach your report, it's already there for you now. So,
Right.
um, and generally speaking, the payers absolutely love our dose and strategy tool.
I'm
Um,
excited for that one, I think the most.
yeah.
That'll be fun to see.
Yeah, and so yeah, I don't want to beat a dead horse here, but we're focusing on multi-domain, multi-informant assessment. This is really we're trying to drive to best practice and give people what they need. We're not trying to tell clinicians what to do. We're trying to give them what they need to make clinical decisions. And then ultimately, we know that this process is going to have to move towards truly assessment-driven intervention, and we think we have the platform to do that. Um, a lot of times people will ask a question sort of, well, how do you fit this into other aspects of the assessment? So this slide was specifically built to help to show you one example. Now, clinical practice is messy. I get it. I'm a clinician. You can't always do everything you want when you want. But this is meant to be sort of an initial guide to sort of an idealized process where you do an interview, you send out and receive the AIM caregiver surveys, you get a lot of patient observations, sometimes structured, sometimes unstructured. You do a skill or criterion referenced assessment, and then you can, now that you've got a lot more information about the patient, you can start to collect the AIM clinical scales. And these are really important to collect here because it sets a baseline for future assessments and future understanding of change in that patient. And then you can also use our dose and strategy tool and then put that all together and develop the treatment plan and the authorization request. Now, some people will say, well, as a clinician, I need even more time with the patient before I feel comfortable. Great, move step 5 to later in the process. It's okay. You can use it as a baseline assessment. I'm not saying this is the way everybody has to do it. I'm just saying this is sort of a way in which we recommend incorporating what a lot of people are already doing in their practice. And then, I've already talked about all this. It's a single to easy to use platform. It's assessment driven treatment. It's designed to monitor change. And ideally, we're going to do this at lower cost with greater value. And we're going to help you guys as practices show off the value that you're providing and at the same time do continuous quality improvement. A lot of new BCBAs need guidance, they need support. And this platform is one of the mechanisms as a practice you can use to train up your clinicians in how to do appropriate assessments and authorization requests. I just thought it'd be good to concretize some of this by doing a quick case example. So, obviously, anytime you do a case example, you're focusing on a very narrow application. But just to give you an example, 4.5-year-old female with autism, without cognitive impairment in this case, but with significant social anxiety, obviously transitioning preschool to kindergarten. We've got some scores from the prior diagnostic assessment. Maybe you don't always have those scores. That's okay. I'm just showing you an example where you would have them. You've got a general cognitive ability or IQ score in the sort of borderline range. Language is a little better than that in the low average range. This female has age appropriate basic communication skills and adequate attention. So, what are the areas of strength? We see an area of strength in social motivation from our assessment. We see basic social communication skills. We actually see sequencing and working memory. And why is that important? Why am I putting it on the side? Well, it tells us that this girl's probably going to do better with more conceptual learning, and focusing on ideas and differentiating ideas. So that's a good sign. It's also a positive prognostic for rapid improvement through therapy. And then emotion regulation skills are good in this case. So you can use our dose and strategy tool. In this case, you put in some information. You can see sort of what the recommended hours are. Um, Remember, it's a range. It's not to be reified. It's meant to be decision support. We're going to see some mixed progress expectations, though, and our system's going to tell you exactly what kinds of mixed progress expectations you'll see. In this particular case, we're expecting a lot of child-led naturalistic teaching because of this profile, right? And again, we based a lot of this strategy guidance on our own experience at Cleveland Clinic with our publications there. And then, we're going to need to pay a lot of attention to generalization and maintenance fairly rapidly in the care because we expect this person to make significant progress. So we want to be thinking about generalization very early on in the process with this particular patient. What are the areas of challenge? Well, perspective taking in relationships are challenges. Self-care is a challenge area for this particular female. Social anxiety, as we mentioned, and caregiver quality of life popped out as an area of challenge. And so, I'm not going to go through all the detail on this, and we love actually training clinics to go through the detail. But in this case, I just kind of want to show you some of the visualizations we offer to support this, right? Both for the parent completed measures and the clinician completed measures. You can see in this case, we're seeing elevated social anxiety. So we color code our figures to make it really easy on the BCBA to say, oh yeah, social anxiety is popping out here. So we need to pay attention to social anxiety. I'm not going to show you all the other ones, but you could see the same with the social communication interaction skills. And why we're really proud of our measure set is because by differentiating all of these subdomains, we give you a chance to be much more targeted in developing your intervention plan, right? You don't just like in a Vineland, it says, oh, social domain is low. Okay, well, what aspect
Exactly.
of social behavior
Yeah.
do I need to work on, right? And as you pointed out earlier, Nissa, like we need to focus on the domains that are most crucial at that moment in time, at that developmental place, right? It's called the zone of proximal development for that individual. And we need to focus on that zone of proximal development. So in this case, AI measures is recommending intervention targets in these areas. And you're able to see a recommended list. It doesn't mean that list is perfect. It means it's a recommended list. And not only do we provide a recommended list, but we tell you which piece of data actually generated that recommendation, right? Was it the parent? Was it a clinician? Was it another educator that you sent out an informant report to? What was generating that recommendation? For that social significance piece that you were talking about before, we want to make sure we're hitting things that matter to the stakeholders that we're treating.
Well, I love the level of individualization here. When this output is developed, these intervention targets, is it just kind of a general, you should target perspective taking, or will you also receive kind of, here's how the goal should be written, here's how
Yeah.
frequently the
Great,
data
great
should.
question. Yeah, no, great question. No, they're much more specific than that. I didn't want to make the slides super messy, to be honest with you. So I kind of
Yeah.
stripped out a lot of the specifics, but no, they're much more specific than that. And yes, any chosen intervention target, if it's a current target, you also have the option, by the way, to select targets for future treatment. But if it's a currently selected target, then that target will move. You'll move on and you can actually develop a goals and objectives and teaching plan from that. All of our goals and objectives are editable, and the teaching plan itself is drop down and editable. So, we're just giving you support. We're not trying to tell you what to do. There may be times when you want to write a goal differently or objectives differently. Totally fine. We're just trying to guide you through the process.
And it's a nice framework to start with. I think sometimes when we get a new client in front of us, we've got all of the historical information and we're starting that parent interview. And then you've also got your other caseloads and emails and things. It is a nice place to have a framework to begin with. And you can say, yep, I want to take these goals and move forward with them. Or, at this moment in time, knowing this learner, I'm going to put these on hold and focus on something else.
Right. Yeah, exactly.
Great.
Yep. Um, so in this case example, we've done 6 months of comprehensive medium to high dose ABA services. So let's take a look and see, what we're seeing on the back end. So as I mentioned, and I'll show you this in the demo, in the short demonstration we're doing later, we offer improvement tables, right? So in this case, we wanted to target social anxiety for this particular girl because that was a major area of concern, in addition to the social communication and the self-care skills. And sure enough, after this treatment, we're seeing improvements in social anxiety. And not only are we seeing improvements, but they're reliable improvements. And they're greater than we would expect given this child's attributes, right? So the percent expected change from baseline you're seeing there is telling us these are more than we would even expect. 100% is expected, greater than 100% is more than expected. And we're using growth scores because these are the most sensitive scores. And for those of you that don't follow this stuff, you can think of these almost like SAT scores, kind of, that's what a growth score metric looks like. The population mean score or average score is 1,000 and the standard deviation is 100. Now, the other thing you might ask, though, is, okay, this is what we're seeing from the clinician. What if the improvement is not observed in the parent report? Well, again, that's a clinical opportunity. Maybe we need to educate the parent about what we're seeing and see if maybe they just missed it. Maybe it's a generalization opportunity. Maybe the parent needs additional training to try to generate some of the improvements at home that we're seeing in clinic, for example. And clinical management changes, our system is designed to help people make clinical management changes. So AI isn't going to replace us soon. Thankfully, we're all going to have jobs. And so what we're trying to do here is say to the clinician, hey, use your experience, use your knowledge of the patient and decide what are the right questions to ask and what are the answers that we think we should generate to those questions, whether it be changing setting, changing intensity, transition, discharge, maintenance, generalization, whatever that is. What do we need to do next? And then I'll just kind of wrap up this part with just talking about the fact that we have a philosophy of continuous quality improvement. We have a commitment to autism and to ABA, my wife and I, and all of the people involved in our work. We want to continue to get better. So we're looking for feedback. If you're thinking about, contacting and doing a separate meeting with us or a demo, we'd love you to do it just to give us feedback. Like we want to improve what we're doing. We want to know what you like and don't like. So please consider doing that with us. We're always improving our measures. Legacy assessments, it might take them 15, 20 years to improve their measures. We're typically doing it on a 2 to 3 year basis. And I think that's the world we live in now, and we all have to move to that. And that's the right thing to do because we're learning so much every day about the best practices that we need to engage in. We've got a lot of innovations coming down the pike. Our Spanish language measures are going to be in the system very, very soon, like within weeks. Our self-report measures for older individuals are on our development timeline for this year. Our webcam performance measures will be in our system later this year, likely in the fall. We're adding in the next few weeks our cross-informant and cross-domain views, so you can look at, hey, the parent said this, the clinician said this, or the parent said this, the teacher said this. And then we are adding in our company level outcome measures, like I told you, those core ABA outcome assessment measures, so that you can engage in value-based care contracting using those measures. And this is just telling you more about our webcam-based assessments. They're all standardized norm reference. We've published on them. You can check out our articles in the American Journal of Medical Genetics, as well as Autism Research. We think this is a really, really innovative thing. You have to have objective measures if we're going to move forward as a field, and they should ideally be standardized and norm referenced. And we want to capture these cognitive benefits of ABA. Why wouldn't we? The ABA works. Let's get those benefits on paper, right? So before we move on to questions, I did just want to spend a minute or two just kind of initially showing you the platform. We have a clinician login. Everything we do is clinician driven. You get a username and password. Once you log in, you'll see your own dashboard, and we can also make sure that for each company that uses our system that we're tailoring it as much as possible to your particular company. In this case, this is kind of a generic view of it, so forgive me for that. But you can see we can see recently completed assessments, recently created individuals. You can even see follow-up assessments that might be coming down the pike if you've got an authorization request coming up. So this is just meant to be a quick and dirty view of what your workflow needs to look like. What you're going to do is spend a lot of time going to the individuals tab. From this tab, you can create a new individual. So I'm going to just show you what that looks like. You go in and put in their name, their sex, their date of birth. And if you have an ID, like a CR ID that you want to put in there, that's great. Or a clinic ID, we can do that as well. So I'm not going to save this because I've already done an example here that I want to show you. But once you've saved that individual, it'll pop up. So I'm just going to pick up an individual I've already entered. If this is your first assessment or you're doing a follow-up assessment, you can click New Assessment Schedule. And once you click New Assessment Schedule, what you're going to do is you're going to first select a date. So in this case, maybe we want to send it out tomorrow. And we don't want it to be due right away, so maybe we're going to give them a couple of weeks. And then you go on, and this is the attribute adjusted scoring I told you about. So if you want to give us more information, we can give you those attribute adjusted scores on the back end. You don't have to have this information at baseline, by the way, either. If you want to provide it right before the next assessment, your second assessment time point, then that's great because then we can score all of these longitudinal follow-up scores for you. So in this case, I'm just going to click Next. this is where you select who you're going to send it to. And I mentioned earlier, we want to promote best assessment practices. So we want you to send it to both parents if they want to fill it out, or multiple clinicians and educators or teachers if they want to fill it out. You're not going to be penalized for this, right? This is different from legacy assessments. We want you to do best practice here. So in this case, I've selected a parent and two teachers. Actually, I'm sorry, two parents and a teacher. And it says teacher, but it should say parent. And then what you do is for each person, you select the domains that you want to assess. And again, we're trying to get you to do more, not less. So you're not penalized for selecting more. In this case, I selected autism, practical living skills, quality of life. You could select other aspects for the core battery here. For the next informant, I just selected executive functioning. And for this person, I just selected challenging behavior. So when you click next here, what it's going to do is it's going to tell you what all you've selected and when it's going to be sent. And so if you're ready and you're like, okay, that's exactly what I wanted to do, then you can click save and it will then save that battery for you. I'm not going to save this one just because I've already got a bunch of batteries that I sent. And what I'd like to do in the last few minutes before we take some questions is just give you a little bit of a view of what the results look like. So in this case, I sent this example schedule and we received the data back. And so you can see here, we've got data from 3 different informants, and I'm going to view the responses. So I go in and click view responses. I'm going to start with the parent here, and we see we've got autism, practical living skills, and quality of life. Every time we do an assessment, we always, for every domain, we check validity. And the reason for that is obviously these are subjective reports. We want to make sure people are filling them out correctly, that there's not some kind of invalid responding pattern. And if there is an invalid responding pattern, we want you as a clinician to know that so you don't overinterpret your data. And if it's valid, you can move forward. If it's invalid, it's an invitation to scroll down and look at the actual responses. So we generate the actual responses to the measures, and we provide those to you at the bottom of each results screen. So, and we color code it too, so you can see which responses are kind of the less favorable responses and which responses are a little bit more on the favorable or functional side. So then, I'm just showing you that for validity purposes. When you're scrolling through, you can see this is a valid administration. You can start to use the figures to see what's going on here. So we see elevated autism symptoms, not surprising. That's why they're in our clinic, right? We can see that there are significant challenges across the board for social communication interaction. So we're going to want to start in these first areas because social motivation and basic social communication are such core areas of functioning. And then on the restricted repetitive behavior side, a lot of times this is about, maybe we're addressing some of these, but we're also oftentimes accommodating some of these. So, for example, if sensory sensitivities were elevated, then that's something we want to consider as a clinician. We want to make sure we're not, we want to make sure we're accommodating and not torturing somebody in these situations, right? We don't want somebody to feel uncomfortable in therapy. We also offer a lot of verbal interpretive guidance here, including any clinical scales in the clinical range. We give you lots of extra guidance about that. And then, of course, you can use that guidance in addition to the recommended intervention targets to start developing your teaching plans. And then we also offer these general recommendations. And the reason why we put this into the system is because some of these are going to be relevant to behavioral intervention, but some of them are like, hey, you need to think about other things. You're a behavioral health home for this family. Maybe this family needs other kinds of recommendations. Maybe they're not getting speech language therapy and you want to reinforce that for them. Or maybe in this particular case, when we're talking about our quality of life measure, maybe this family needs access to more resources in their community or supports. And that's something you can reinforce in your practice. And then we also offer tables for interpretation. And I know I'm going through this quick, but we train you guys on all of this. We even offer copy paste functions. So like you can pull it out and show other clinicians or, interact with the information. Sometimes you're seeing progress. You just want to show it to the family. Like, oh man, we've seen a ton of progress in this area. So we're going to show it to you guys.
In
And
looking
then you
at
can,
this, Dr. Frazier, I do have one question. When
yeah, please.
we're looking at the results, do most of the clinicians that might use AI measures, do they take these results and cut and paste them to their own templates, or is there a general report that they might just take that is a easy, plug and play kind of, this is the report from AI measures, go ahead and submit this with your funding
Yeah.
source? What's
So
the
yeah, great
practice?
question. And thank you for reminding me. So this is the report. What the report does is it aggregates all of the information, including the individual's information and the informant information, and it puts it together so that you can see exactly what each informant reported on, what the results were, and you can do that informant by informant. We have some people that are using our system that do use the copy paste function and put it into their own templates. You're welcome to do that. You're also welcome to take this, and I'll just keep scrolling so you can see it aggregates all of the information together. Um, once you take all of this information together, you can actually just PDF this. And so you can PDF print this, save it as a PDF,
Okay.
and put it into your system. And yeah, so thank you for that. And then, I do want to make sure, I know this is a lot to cover in a short amount of time. I do want to make sure that, like, in our trainings, we not only walk you through, but we also provide case examples and supports. And my wife Allison is amazing at supporting BCBAs and learning how to do this. So we're definitely there for you for this. And then just quickly, I'll show you a little bit of the dose and strategy tool. So in our dose and strategy tool, you can, tell us what information you have available. And if that information is already collected, it'll pre-populate like the practical living skills scale just did there. And if it's not available, but you have it somewhere else, like you just got it through a diagnostic report, you can, put that in here. You don't need to have everything, so I'm actually going to skip language just to show you. If you've got an autism symptom measure, you can add that in. If you've got in this case, a parent measure, that's already going to pre-populate for you. We need to know about challenging behavior. So we tell you what the challenging behavior scale said. In this case, this person does not have challenging behavior, so we're just going to click none. But you can imagine a situation where somebody had pretty significant challenging behavior. That also is going to play into the dose and strategy. And then we list the quality of life results here because we want you to tell us about the parent readiness for behavioral intervention training. And, in this case, we might select moderate readiness. We also ask you to tell us a little bit about the setting, and in the interest of time, because I want to get to questions, I'm not going to fill this part out, but it is an optional part. It does give you more information. And then the same thing with filling out whether it's a baseline or a follow-up assessment. This allows us to just more tailor the report. But once you save this, you can see that there'll be a recommended hours for you, and then you can also download the report. And once the report is downloaded, you can actually scroll through the report and see, exactly what the guidance looks like. So we give some use and documentation guidance, the dose and strategy, and then we go through general intervention strategies, teaching strategies, learning type, all the stuff I talked about earlier, reinforcement guidance, progress expectations, etc. So we'd love to show you more of that and help you guys to understand the value of that for your practice. Hopefully we get a chance to do that with you. But that was kind of what I planned for today. Obviously, there's a lot more to show, but I'll leave that for individual interest.
I think we had answered all the questions live, although one just popped in here. One question that is in our chat for us: what does the webcam objective measure look like, and how is it done?
Oh, this is a great question. So, yeah, and we've published on this, so you can read some of what we've written about it. But essentially, we have 5 different paradigms, visual paradigms. Each one is 3 to 4 minutes in length. Each video itself is only 1 minute in length because we know for younger kids, you have to be very brief with them. So just to give you an example, in our social attention paradigm, we show a bunch of different types of social stimuli, everything from side-by-side faces that are making facial expressions to individuals engaging in joint attention or directed gaze to just naturalistic scenes where people are interacting with one another. We use the AI, that's why our name is AI.Measures. We use AI to measure gaze and facial expression to the screen. And then from that gaze and facial expression information, we can identify particular cognitive skills, social attention, general or sustained attention, receptive vocabulary. So in our receptive vocabulary paradigm, it's very simple. We show objects on the screen and we say, look at the ball, look at the person kicking, look at the gift. And they get harder and harder as you go for that paradigm. For the social attention paradigm, they don't get harder and harder. It's just naturalistic viewing. But for the receptive vocabulary paradigm, they get harder and harder. And obviously, for younger kids or more impaired individuals, they can skip out of that. They don't have to, we don't have to make them go through all of it. We can get enough data usually with just 1 or 2 minutes of data. We do allow people to take breaks. In that system, we train people to parents to actually help their child through the process, and we also, of course, train clinicians as well. I'm actually just going to show you a video. It makes it's a lot easier to understand it if you just look at the video. And so I'm just going to show you the video right now. It's a really sort of nice, easy way to understand what we're trying to do.
Follow the red car. Follow the yellow bird. Eyes to find the pictures. Look at the toy. Look at the fish. Look at the orange. Look at the ball. Watch videos. Remember, some will ask you to look at certain things. Which one do you want?
I think I'll try the grapefruit. Oh, thank you.
You're welcome. Find all of the cars as fast as you can. Go. This is a taco. Find all of the tacos as fast as you can. Go. Use your eyes to find the shape that you just saw. Keep looking at the shape.
So yeah, again, I just wanted to, it's easier to see it. It goes much slower. We sped that up for just to get you guys through it quickly, but it goes a lot slower. We train the parent and the clinician how to administer it. As you can see, we've done this in very young kids, including we have data in individuals with autism and neurogenetic syndromes with significant intellectual disability. So we can't get every measure on every person, but we can usually get really good data, including some facial expression and gaze data on kids. And then, of course, that helps us to objectively track their progress as they make gains in therapy.
That was really great. And I'm sure that would lead to many more questions in regards to what's the output look like for that type of data set. How can we interpret that and have a discussion on that? I know we are hoping to host another webinar with some CEU content added there. So I know that's something we'd love to share with everyone that is participating today. We'll send another follow-up for another AI Measures webinar with Allison and Thomas here. But if there aren't any more questions, there aren't any in the chat. If you have any lingering questions that you'd like to ask, we just have a few more minutes here, maybe 1 minute. Otherwise, thank you so much for joining us today. And I know we do send out a post-event survey. So if you do see that, please, it'll pop up in your browser. As we're wrapping up here, please feel free to provide us feedback on the webinar. And we hope to see you all at the next one.
Thanks, everyone.